get started today. Here's the announcement I sent you by email. Two talks today in the biology flow plan. Hyrule will be talking about his summer research at Baylor College of Medicine on a project related to brain cancer. And my will be talking about their summer research here at Irwin on a project related to spinal cord injury. Noon today, CST 103. You're all cordially invited. Okay, so today's goals are to review some anatomy. We'll play some anatomy games. We'll talk about the microscopic anatomy of the nephron. That's more review from last time. The new concept is this thing called platelets, which we'll spend some time on, and which will be covered on the quiz. And then, if there's time, I'll talk about control of glomerular filtration. If there's no time, we'll push that back to next week. Okay, Hyrule, you have the honorary laser. Pass it around. Pick a box, give me a name. People agree that this is the medulla?
That would be the cortex.
That would be the cortex. Okay, pass it around, pick a box, and give me a name. Yeah, ureter. That's it. Yeah. Okay, so I can see what you're saying, yes. So if it were pointing to here, if it was pointing to this spot right here, we would call it a papilla. If it's pointing to this area right here, what would we call it? A minor calyx. And, okay, and if it were pointing to, let's just say if it were pointing to here, what would we call it? A major calyx. Okay, is that clear? Okay. Pelvis. I guess I will not take points off if we don't include the word renal. It's pretty obvious. It's pretty much everything we're talking about today is coming to the rest of this section of renal. Yeah. Renal artery. And if this image was in black and white, how would you tell the difference between a renal artery and a renal vein? Thicker. The renal artery would have a thicker wall. Not a bigger diameter, but a thicker wall. Yeah.
The coal-like structure will be the pyramid.
Yes, so that's right. So, well, let's think. So if we're talking about the layer, what would we call it?
Layer, like between the medulla and the
Well,
cortex, or
What is, so, yeah, so what's the layer between the cortex and the pelvis calyces area in the middle? This, what is the name of this layer? No. You said the word, I just didn't hear it with the confidence and the expression that I was hoping for. Begins with an M. That is the medulla. The medulla is the layer. Now, And you said it, you said it was between the medulla, but no, that is the medulla. Okay. And the structure, if I was asking for the name of that structure, what would you call it?
Pyramid.
Pyramid, yeah. Okay, and I suppose there's a box here that isn't shown, but we could, well, let's pass the laser to somebody else and get the last one. Emily, do you remember the name of this structure that is in the medulla, but between two pyramids? Columns. Okay, questions? Yes.
So I think previously you say that the columns is a part of the medulla, but still, it's just an extension of the cortex, so would be.
Anatomically, it's part of the medulla. Physiologically, it behaves like part of the cortex. You'll see. It has glomeruli in it, just like the cortex does. It has short cortical nephrons, like the cortex. It actually also has some juxtamedullary nephrons because it is, you know, this column has surface in contact with the medulla, with the pyramid.
So for example, if this question is, what will be the structure lying in what will be the structures which compose the medulla vulvalis?
I guess I wouldn't ask that question.
Okay.
Yes.
So if the picture wasn't a black and white picture,
Yeah.
all the drawings seem to draw arteries on the front and the veins are on the back. Does that make sense?
Yeah, see,
Yeah, is it always?
I'm not sure that's true.
Okay.
And many of the drawings draw the artery more superior and the vein more inferior, and I'm not sure that's true either. Okay? So let's continue this game. Here's some answers that are printed out. Let's just see if we got it right. Yeah, we have more detail than the answer key, which is good. Extra credit for us. So the layer is the medulla, the structure is a pyramid, cortex. 110% for us. Good. Okay, so remember that the main role of the glomerulus is to form the filtrate, and we form a large volume of a very dilute filtrate. Then the job of the tubules and the capillaries is to reabsorb most of what was filtered. Most of the water, most of the sodium, most of the potassium in many cases, chloride, phosphate, all of the glucose. A lot of what was filtered is recovered by a process called reabsorption by the tubules and the capillaries that surround them. And then the urine is what's left over, and that's what we excrete as urine. Okay. Let's play this game. Who's got the laser? Pass it around. Go ahead. Pick a box, any box. And, well, let's try to stay over on this side so I don't have to slide the chair back and forth too much. So pick a box on this side of the figure and give me a name.
I'm just gonna put the easiest, so this is the glomerulus.
Okay? Glomerulus.
Thanks.
So this
Gosh.
is the glomerulus. Okay?
This one is the Hinman family, right?
Okay, but there's two boxes, so there's a descriptor of the two different parts of the loop. You definitely got.
Linear and Ziegler, is that what you're looking for? The thick and thin?
No, that wasn't what I was thinking about. Up and down. Somebody help her out. Ascending and descending. So let's just try to follow this. So here's the proximal. This is the descending limb, that's what they call it, limb of the loop of Emily. And this would be the ascending. Oh, by the way, this figure is in your handout. It's on the back of, it's on page 2. So it's there, you got it, it's just not on page 1. You can see why I put it on page 2, it's because I had two figures that were big and I did just to minimize the amount of data. Okay, who's got the laser? Okay, now.
Bowman's capsule.
Okay, good. Bowman's caps. Okay,
This one here is the macula densa.
very good. Macula densa.
This space, the medullary collecting duct.
Okay, let's, I can't, so it doesn't matter. Which one is the medullary collecting duct? Okay, good. Medullary, because it's in the medulla, medullary collecting duct or tubule.
This is the proximal convoluted loop, or
Tubule? Tubule. I'm not sure I can reach it. So you're pointing, it's this one here? No, it's
this one.
this one here. Okay, proximal tubule. If you can call it proximal convoluted tubule, or you can just call it the proximal tubule.
Wait, did you point to it one more
Yes, I
time?
can. This here no. Is the proximal tubule.
That's the cortex.
Okay, good. So this layer is the cortex.
That's the medulla.
Yep.
That's the cortical collecting duct.
Yep. Cortical collecting duct of the tubule. Okay, good. Say again? Which one are we pointing to? This one right here?
Yeah.
And what are you calling it?
The
Efferent or afferent?
efferent.
Well, let's see. Blood is coming in through the red, so
Okay.
this would be the afferent arterial. And then what's this one? This is afferent. And we said this is the glomerulus. What is this one here? That's right, that would be the efferent. So I'm just going to okay, here's the blood coming in, branch of the renal artery. So this tube is going in, and that makes it afferent. And then this tube is coming out, and that makes it efferent. that's the word we're looking for. Peritubular, which means around tubular, around the tubules, peritubular capillaries. Okay, almost there. That's the distal tubule. Okay, good. So this bar here is referring to this collection of capillaries, which is the vasa recta. And I don't know, I guess this is the appendix. Oh, this is getting at thin versus thick, which we're not paying attention to.
So these are all the terms that we would need to know.
Indeed they are. Everybody caught up? Moodle will be the information. So Moodle actually included, the textbook included this thing as being the renal corpuscle. So that is a correct answer. The renal corpuscle being made up of Bowman's capsule and the glomerulus, the pieces that we got. Descending lupus Henley, ascending thick thin we don't care about. Vasa recta we got. I guess it was pointing to the name of nephrons. So this is a cortical nephron, and this is a juxtamedullary nephron. I don't even know if we have that. Medulla, cortex, afferent and efferent arterioles, cortical collecting duct. Proximal tubule, distal tubule, peritubular capillaries, proximal tubule, right? Okay? So Moodle has this answer if you missed something on your worksheet. All right, let's do one more. Good. Okay. Well, there's going to be, since there's two lines coming out of this box, this is Bowman's capsule. And somebody want to volunteer what that line is pointing to? Color? Podocyte. Some body of the podocyte because that's where the nucleus is. That's what that dot is supposed to symbolize. So this is also pointed to a podocyte. I don't remember exactly what the book is trying to get out of this, but that's what we put there. Okay, who's got the laser? There we go.
This will be efferent.
Efferent, right. This would be the efferent arterial. How did you know it was efferent and not afferent? There's a hint on the slide. There's two hints actually on this slide. Yeah, blood is coming out, so that's efferent. That's the most obvious hint.
The box right below, like underneath the podocyte will be the glomerulus.
Yeah, okay, we could just call that a glomerular capillary. That would be the correct. Oh no, that's this box. I'm sorry, I got this wrong. So this, let me fix this, because that's not right. If we pay attention to where the line is drawn, this box is pointing to this structure here. So now revise, you don't have to choose that box anymore, just give me a different answer.
So either afferent or arterial.
Okay? Is it,
Oh,
it's
yeah,
one of the
afferent, then.
arterioles, which one is it?
Afferent.
Yeah, you figured it out by elimination. This is the afferent arteriole. Okay? So if that's the afferent arteriole, what do we call the structure that connect? Well, anybody, pick a box and go.
Is the one above after arterial the distal tubule?
The one above the afferent arteriole is the podocyte.
No, the one above efferent.
Oh, the one above efferent is the
Efferent,
what?
sorry. Distal tubule?
Yes, that would be the distal tubule. Good. All right, then what are we calling the structure that makes the contact between the distal tubule and the afferent arteriole? Actually, there's two words here. One of them we had on the board before, macula densa, is actually a specialization of the distal tubule. And what are those purple things between the macula densa and the afferent arteriole?
Juxtaglomerular?
There it is, juxtaglomerular cells. So they're in contact with the macula densa. And they make the contact between the macula densa and the smooth muscle of the afferent arteriole. All right, let's finish up. Let's go over here. This is just pointing to a capillary, a glomerular capillary. And what is this? This is pointing to this thing right here, the proximal tubule. And if we wanted to label this part right here, what would we call that? Bowman space. Okay, so I think we have, so this is a podocyte. What are these? Who's got the waiver? Okay, what do we call these lines here? These
Filtration slits.
Filtration slits. And what do we call these holes on the inside of the capillary? Fenestrae. Okay, these are also things to know for the quiz. So you've done very well. My guess is you were using open book strategies for this particular exercise. Remember, the quiz is not open. It's closed. Any questions about any of this terminology? Whole language of renal anatomy. Okay, the answers are on the, just get confused. Okay, just a refresher about filtration. What favors filtration is the hydrostatic pressure in the glomerular capillaries. And that's what, I need the laser. Who's got this? That's what this big arrow is supposed to be illustrating. The pressure is driving water, it's driving fluid from the glomerular capillaries into Bowman space. there are two forces opposing that flow. One is the pressure in Bowman space, which is relatively minor, but not zero. And that's hydrostatic pressure in Bowman space is against the hydrostatic pressure in the glomerular capillary. So that makes sense. It's just opposing hydrostatic pressures. And then, in addition, there is solute in the glomerular capillary, specifically albumin, that didn't get filtered. And so its concentration is increasing as filtration happens. And if we have a fluid with a high concentration of solute in permeable contact with a solution of lower solute, then water flows from the lower concentration of solute to the higher concentration of solute, osmosis, and that's osmotic forces or osmotic pressures. So remember, the osmotic forces drive water from low concentration of solute to high concentration of solute, trying to equilibrate, trying to equalize the concentration of solute. This is passive. And so we have hydrostatic pressure that favors filtration. We have two things, the Bowman space and osmotic forces tending to work against filtration, and then we have a net filtration pressure. And if the net filtration pressure fell to zero, filtration would stop. But typically it doesn't go to zero. It's just, the point is filtration pressure is not just blood pressure. That's the main. Okay, so let's do a clicker. Y'all should have a clicker. Got extras here. This is following up on the idea of osmosis. I'll give you a little hint there. There's one excellent answer and, well, there's two correct answers. C and D. So the flow is from a dilute fluid to the concentrated fluid, that's osmosis. And we say that a dilute fluid has the higher osmotic pressure. It's weird, but that's what we say. Because fluid is flowing from the dilute fluid to the concentrated fluid. So the dilute fluid has the higher osmotic pressure. It's a little weird. We don't talk about negative. You could say, well, the higher concentration fluid is sucking water from the lower. Why isn't that? Why don't we just call that negative pressure? Yes.
Can you come back to the previous cartoon? The previous cartoon. Like in reality, there will be no space between the.
That's right.
Yeah.
I mean, no space. There are cells layer. There's a cell layer, but there's no extracellular space. It's cells pressed up against cells. Basically, endothelial cells pressed up against podocytes. Okay. So now, glomerular filtration can be controlled. I want to do this now, but and we'll get to the mechanisms of glomerular filtration at the end of class if there's time. But the key concept that you need to know for the quiz is that glomerular filtration is controlled by the constriction of the afferent and efferent arteriole. So let me walk through this. So this is a cartoon of this is the afferent arteriole, this is the glomerular capillaries, this is the efferent arteriole. In this simplified cartoon version, afferent, capillary, glomerular capillary, efferent. Okay, so they're all that way. So if we constrict the afferent arteriole, then we constrict it here, there's less pressure in the glomerular capillary, and so this would decrease filtration. We're going to talk about glomerular filtration rate in a minute. GFR stands for glomerular filtration rate, the rate of glomerular filtration. So if we decrease the pressure in the glomerular capillaries by pinching off the afferent arteriole, we decrease GFR. If we dilate the efferent arteriole, then the pressure in the glomerular capillary is decreased because there's this big tube that this glomerular capillary is connected to, and that sort of drains the fluid and lowers the pressure and lowers GFR. So we can constrict the coming in, or we can dilate the going out, and both of those would decrease glomerular filtration rate. And now we can do the opposite over here. Your kidneys do the opposite. If we constrict the efferent arteriole, constricting the outflow, then the pressure in the glomerular capillary is going to increase, and glomerular filtration rate will increase. And then finally, if we dilate the afferent arteriole, then we're bringing more blood into the glomerular capillaries. More blood, more pressure, higher filtration rate. Okay? So this should be intuitive. Dilate the afferent, constrict the efferent, both increase filtration pressure, increase filtration rate. Constrict the afferent and or dilate the efferent decreases filtration pressure, decreases filtration rate. It's as simple as that. So let's do a clicker around that. Which of the following, individual or in combination, would cause a maximal glomerular filtration rate? What would you do, individually or in combination, to maximize GFR, glomerular filtration rate? Good, I'm seeing a lot of the correct answers. Dilate the afferent or constrict the efferent.
So can it happen at the same time?
Yeah, it does. Okay, which of the following would decrease glomerular filtration rate? Okay, so now we're not just talking about constriction and dilation. There's some other things that I'm adding in. Which of the following would decrease overall GFR, glomerular filtration rate? Okay, I see a lot of mostly and a lot of fully correct answers. They're all. Constriction of the afferent arteriole would decrease filtration pressure, decrease filtration rate. Dehydration is going to cause it's going to cause a decrease in blood pressure, first of all, but it will also cause an increased solute concentration. More solute, that is to say more albumin, more hydrostatic pressure more osmotic pressure opposing filtration, so that would decrease filtration rate. If we decrease the number of glomeruli, we decrease the filtration rate, and if we block, we gum up the filtration works, we decrease the filtration rate. So they're all correct. Questions about this? Okay, so let's talk about clearance. This is a concept that I want to introduce. We'll spend the next 45 minutes talking about clearance. Maybe it won't take that long. The book doesn't do this, so this is information that you have to get from here. Clearance is, so physiologists and pharmacologists talk about clearance as how the body gets rid of stuff, clears it from the body. And our bodies have two forms of clearance: renal clearance and hepatic clearance. Our kidneys get rid of stuff, and our livers get rid of stuff. We're not going to talk about hepatic clearance until we get to the digestive tract, but the concepts are the same. Right now we're going to talk about renal clearance, how the kidney clears material. It clears material we don't want, and it actually clears some material we do want, like water, in the process of clearing the material that we want to get rid of. So clearance is the process of getting rid of the material, clearing it from our body. So let's talk about the overall processes of excretion. So excretion means it's in the urine. There's three things that go into excretion. Filtration is the first step by the glomeruli, and then the tubules reabsorb, so filtered, and then material can be reabsorbed by the peritubular capillaries and or the vasa recta, the capillaries. So this is filtration, reabsorption, and in some cases there is actually secretion from the glomerular from the peritubular capillaries or the vasa recta into the tubule. So there's three processes. We filter it, we reabsorb it, and we secrete it. The amount excreted is filtration minus reabsorption plus secretion. So this operator is filtered minus reabsorbed plus secreted, gives the amount excreted. Don't confuse secreted with excreted. That's an important thing to differentiate. Excretion is what ends up in urine. Secretion is the process by which some material gets into urine. It gets into urine either by being filtered and or secreted. It gets out of urine by being filtered and then reabsorbed. Okay, so this is the overall flow chart of the operation that we're going to be talking about for the next week and a half, 2 weeks.
So would it follow subtraction first?
That's the way I think about it.
Can you say how secreted and excreted are different?
Excreted is the final result, and secreted is one component to how something is excreted. Something is excreted if it is filtered or secreted and not fully reabsorbed, for example. So excretion is what's in urine. It's the common usage. We talk about excretion. You know what excretion is. But this is the common word for what ends up in urine. If it ends up in urine, we're excreting it. Some of that might be from a process called secretion, which is this process of moving something from capillaries into the urinary fluid. So I will take points off. If you talk about the amount secreted in urine, that's just not the right language. Vision.
Was the material we covered last time related to common filters, sodium, potassium, glucose?
Yeah.
Filtered from capillary to glomeruli.
Sodium, potassium, and glucose are freely filtered,
And
and they are all at least partially reabsorbed. None of those three materials, none of them is secreted. glucose is fully reabsorbed. 100% of the glucose is reabsorbed. You'll see that for sodium and potassium, it's not 100%, but a lot of it is reabsorbed. All of those three things, sodium, potassium, and glucose, are filtered and partially or fully reabsorbed. Okay, so we're getting to clearance soon. There's more jargon. So we talk about the excreted load. What is the load? What is your urine carrying out of your body? The excreted load. And so what it is it's the flow rate. And this is a flow term. The excreted load is a flow term, so we're going to have time in there. So it's the flow rate of urine in it's the flow rate of urine in milliliters per minute. Right? You know, you are right now generating urine at some rate. You're not urinating right now, of course, but you are generating urine and it's going into your urinary bladder. It is happening right now. And that urine that you're generating has a concentration. So and we talk about the excreted load of each thing, each solute that's in your urine. So the excreted load is the flow rate of production of urine, milliliters per minute, times the concentration. The concentration of X in urine is, and you could say, well, why don't you use why don't you just call this X in urine? Sort of, yeah, I could do that too. It's the same thing. And I will, if I ask you to show me an equation and you use that terminology, that's fine too. So, mils per minute times milligrams per mil, or milliequivalents per mil, gives you a final product of milligrams per minute, or milliequivalents per minute, or millimoles per minute, or whatever it is. It's a flow rate. I mean, it's a rate. It's a rate of excretion. That's the excreted load. Pretty simple. So let's do some quick questions with excreted load. A person produces 1 mil per minute of urine. That's typical. That's what's happening in all of us right now. Those of you who are drinking water robustly are probably generating more than 1 mil per minute of urine. The concentration of glucose in urine is 0 milligrams per mil, normally, unless you have diabetes. And the concentration of sodium is 100 milliequivalents per liter. Millimolar. What's the excreted load of glucose? Yeah, that was pretty easy. 0. I'm not going to show you the answer because they're both on the next slide. Okay? 0 milligrams per minute is the excreted load of glucose. Oh no, I fixed it. There we go. Oh, I have both answers on one slide. What is the excreted load of sodium? I'll give you a hint. There's a trick here. And I'm pointing this out because this is the way it is. You have to pay attention to mils per minute. Pay attention to the units. How many milliliters in a liter? 1,000. How many milliequivalents are in a mil? Well, show me your answer. Let's just see if you got it right without me throwing some. Okay, so you mostly got this just fine. You converted milliequivalents per liter into milliequivalents per mil. You did this in your head. You just said, okay, 1,000. 1, 2, 3, 0.1. 0.1 times 1 is 0.1. Okay? Don't let me trip you up with the units of volume. Pay attention to whether I'm talking about per mil, per liter, or a new term that you probably have never heard of, a deciliter. We're going to see another term because physicians, clinicians, use another term. They use mils, they use liters, and they also use a thing called a deciliter, 1/10 of a liter. Okay, clearance, finally. Now, so I'll introduce it, and then we'll go through some examples after a break. So here is the equation for clearance, and you do need to know this. And it will be helpful to know it for the quiz. No, you probably, yeah, you should know it for the quiz. Well, I'm just going to translate this equation into words to help it make sense. The clearance of something is equal to the flow rate of urine times the concentration of that substance, the clearance of X, clearance of a substance, sodium, clearance of potassium, clearance of urea, clearance of glucose, clearance of acetaminophen that you took because you had a headache this morning, Tylenol. The clearance of anything is the flow rate, assuming it's cleared by the kidneys. I think acetaminophen is actually cleared by the liver, but whatever. Volume flow rate of urine times the urine concentration of that substance divided by the plasma concentration of that substance. So that's the equation. And if you look at this, you say, okay, well, there's the excreted load. So if you know the excreted load, you just put the excreted load in the numerator and divide by the plasma concentration. And that gives you the clearance of the substance. Now, what's weird, what confuses people, is that we're talking about the clearance of something. Clearance of X, clearance of glucose. But if you do the units, the unit of clearance is in milliliters per minute. The clearance of sodium, the units of the clearance of sodium is not going to be milliequivalents per minute. That's the excreted load. The clearance is going to be in milliliters per minute. And so the clearance of everything is in milliliters per minute. And so if you say, well, milliliters of what? It's the milliliters of plasma that contains the amount that is in urine. If you need a language, some people don't, you can ignore this if this makes you more confused. But the thing to know and to remember, because it helps you make sure your calculations are right, is that the units of clearance are mils per minute. And if you need to know what is the mils it is of, it's the mils of plasma that has the material that is in urine. So let's go through one quick example, two quick examples, and then we'll take a break, because I think it'll help clear things up. So here's an example of a substance. The substance is serum albumin. It is not filtered nor secreted. So the urinary concentration of it is 0. So the excreted load is 0. So the clearance is 0. The volume of plasma that contains the amount of albumin that is excreted is 0. 0 mils of plasma has albumin in it. So in order for clearance to be 0, it just means the amount of plasma that is cleared of albumin is 0 mils per minute. None of the albumin is cleared. No volume of plasma is cleared of albumin. Okay? So the clearance of albumin is 0 because it is not filtered or secreted. Let's do one more, and then we'll take a break. Here's a substance that is freely filtered, but completely reabsorbed. This is glucose. Glucose is freely filtered, but it is completely reabsorbed. It is freely filtered, but it is completely reabsorbed. Let's just get these, so, I'm sorry, I should have done this on the previous slide. This is the glomerular capillaries, Bowman's capsule, Bowman's space, epithelial cells lining the tubules, generic tubules, generic peritubular capillaries. That's what this is. Glomerular capillaries, peritubular capillaries, tubules. Freely filtered, completely reabsorbed, none of it is in urine. So, if the urinary concentration is 0, then the excreted load is 0 and the clearance is 0. So we have two ways of having a clearance of 0. Either it is not filtered at all, like albumin, or it is freely filtered but so completely reabsorbed that still none of it ends up in urine. And so again, there is no volume of plasma that actually is cleared of glucose because we reabsorb it all. Let's take a break because we'll get to some more complicated versions of the same story after break. Let's refresh, a short break. You might need to drain your urinary bladder and then we'll continue. So remember, example 1 was a substance like albumin that is not filtered, and the clearance is 0. Example 2 was a substance like glucose that was filtered but was completely reabsorbed, and the clearance is 0. Now we're going to talk about a substance that is freely filtered but not reabsorbed or secreted. So it is freely filtered but not processed by the renal tubules. Freely filtered, but not secreted or reabsorbed. So what is in urine is what was filtered. The only way it got into urine was through filtration. Didn't come out of urine, didn't get put into urine by the tubules. So in this special case, a special case of something that is freely filtered but not reabsorbed or secreted, the clearance of that substance is the glomerular filtration rate. Because the only way it ended up in urine was through glomerular filtration. And so the rate of clearance, which is in mils per minute, is the glomerular filtration rate, which is in mils per minute. So if a substance is freely filtered and not secreted or reabsorbed, then the clearance is the GFR, but only if the conditions are met. And an example that we use, so clinically, there are two examples. One is to use a substance that's normally in your blood called creatinine. It's a byproduct of muscle metabolism. Some of it is in your blood. It is pretty much filtered and not secreted or reabsorbed. So it's a pretty good measure of glomerular filtration rate. We can measure the amount of creatinine in urine. We can measure the amount of creatinine in plasma, calculate a clearance, and say, okay, that clearance is the GFR. So creatinine is an endogenous molecule that meets the criteria. Inulin is a better molecule. It's actually, but we don't make it. We have to, and in fact, we can't digest it. So if you want to use inulin, it has to be infused into the bloodstream through an IV. So that's rarely done, but it is another one. Inulin, this is not insulin. It's not insulin, this is inulin. It's a carbohydrate from certain, like Jerusalem artichokes has inulin in it. I just happen to know that. It's not a testable
Trivia
bit
question.
of information. Anything that is freely filtered and not processed by the renal tubules can be used to measure glomerular filtration rate. Similarly, anything that is freely filtered, but if the reabsorption is completely balanced by the secretion, if these two things counterbalance each other, then that substance can also be used to measure the GFR, because what is in the urine came from filtration, because these two things cancel. So they either don't exist, which is the case for creatinine and inulin, or if they cancel, that would also allow the clearance of that substance to measure glomerular filtration, because the only way it got here was through here. And creatinine and inulin are the two molecules that we use to measure GFR. So now let's take another special case. A substance is freely filtered and so robustly, so actively reabsorbed that none of it exits the blood, exits the kidney. All of it that enters the blood, all of it that enters a kidney ends up in the urine. Because it was filtered and reabsorbed. And there is a case, there are molecules that do this. Para-aminohippuric acid. So now the volume of blood plasma, that has what is in the urine is the amount of plasma that flows into the kidney. And so the clearance of something that meets these criteria is measuring the amount of plasma that is entering the kidneys, the renal plasma flow. This is another special case. Let's get to the sort of a generic case, and then we can back up to special cases if we want. Here is a generic case. We're talking about sodium, potassium, calcium, urea, normal things. Some of it is filtered, some of it is reabsorbed, some of it ends up in urine, and now we just use the equation to calculate its clearance. We've been using this equation all along, but I've been taking special cases. In this case, the clearance is the flow rate of urine times the urine concentration of the substance divided by the plasma concentration of the substance. That's the clearance. And there is a clearance of sodium, there's a clearance of potassium, there's a clearance of urea that we can calculate using the clearance equation. In this case, the filtered load is what is the filtered load. Oh, this is a new concept. So we've talked about excreted load. Remember, the excreted load was the volume flow of urine, mils per minute, times the amount in urine, in mg per mil. And that the excreted load was milligrams per minute. We can also talk about a filtered load. If we know GFR, so this is mils per minute of filtration, times the plasma concentration of that substance. The flow, the glomerular filtration rate, times the concentration of the thing in the plasma gives us a filtered load. Just another terminology. So let's do some problems, and maybe hopefully things that are confusing now will become less confusing if we just attach some numbers to it. Okay. So let's look at creatinine. 1 milligrams per deciliter. Okay, milligram. So you have to pay attention. Deciliter, milligram per deciliter. So that's a milligram per 100. A deciliter is a tenth of a liter, or 100 mL. Don't let me trip you up by putting in that little lowercase d there, and you think that the d is the same as an m for milliliters. A deciliter is not a milliliter. We can convert deciliters into milliliters, and so 1 milligram per 100 mLs is 0.01 milligrams per milliliter. I'm doing it for you, but I won't do it for you all the time. Okay? The urine flow rate in this case is 1.2 mils per minute. Somebody in this room is having a urine flow rate right now of 1.2 mils per minute. It's a typical value. The concentration of creatinine in urine is, in this example, 0.95 milligrams per milliliter. Just the concentration that's in urine. Okay, so now use the clearance equation. to calculate the clearance of creatinine. And then somebody tell me a number. You all have calculators in your pockets. You can do this, not a hard calculation. Somebody tell me an answer. What'd you get? Did you say?
Yeah, 114
That's what I get too. 114, what are the units? Right, milliliters per minute. How do we get that? Well, we took the flow rate, 1.2 times 0.01 divided by 0.95. The units here cancel, we're still in mils per minute. That's how we got that number. It's a normal number. 114 is in the normal range. It's between 90 and 120, 125. What is the GFR of this patient? 114, because the clearance of creatinine is a measure of GFR. So the GFR is 114 mils per minute. So if I ask you a question, what's the GFR of a patient, but I give you information about the creatinine concentrations, you can calculate the GFR from the creatinine clearance. Yeah.
I think it's 2 times
0.95.
Oh, that's right, you're right. Completely right, sorry. Yeah, completely right. As soon as you started pointing that out, I noticed. 1.2 times 0.95 divided by 0.01. Sorry. Okay, what is the filtered load of creatinine in this patient? Let's remember the equation for filtered load. Filtered load is GFR times the concentration of creatinine in the plasma. What do you get? 1.14. What are the units? Milligrams per minute. And what is the excreted load of creatinine? So remember the formula is the volume of urine, the rate of flow of urine times the concentration of creatinine in urine. Now, if you can calculate it, or you can realize, wait a second, we're talking about creatinine. It's a special case. What is the excreted load of creatinine? Same, 1.14 milligrams per minute. Because what is excreted for creatinine, what is excreted is filtered. You can either do the calculation and prove that, or you can just say, well, it's got to be the same here, just the way you made this equivalence here. It's the argument is semicircular because the definitions are semicircular. Okay, let's go to the same person. Same blood draw, same urine test, same person. Para-aminohippuric acid in the plasma is 10 milligrams per deciliter. And the concentration of urine, of para-aminohippuric acid in urine is 50 milligrams per mil. For both of these, why am I circling it out? I won't do this for you on a test. So what is the clearance of para-aminohippuric acid? Somebody give me a number.
$600.
600. 600 units? Milliliters per minute. Remember, I'm trying to illustrate that. You need to give me the units. Without the units, you don't get full credit. You don't have to show me the units in the calculation if you get it right at the end, but it might be helpful to put the units in the calculation to make sure you're seeing what the cancellations. Why is the clearance of para-aminohippuric acid different from the clearance of creatinine? What's the mechanism? What's the biology there? It's not mathematically, but biologically.
The creatinine is only filtered, but the pH is filtered in.
Exactly. Creatinine is only filtered, and para-aminohippuric acid is both filtered and then completely secreted by the renal, by the capillaries and tubules. Okay, so here are the answers with some calculations that will be on Moodle soon. Okay, let's do a little bit more. Okay, same patient, yes.
For that last question, since PAH is secreted too, would you be able to use the filtered load calculation, the same equation for that, for PAH?
You could use the filtered load, and that would tell you some of the excretion of PAH, but not all of it.
Okay.
The filtered load, yes, you could still use that equation to tell you the filtered load, but it doesn't tell you the excreted load, because there is a lot of it that is secreted. Okay, same patient, that is to say, same GFR, same urine flow rate, everything is the same patient, same blood draw, same urine draw, etc. Okay, so the serum sodium concentration is 140 milliequivalents per liter. The urine concentration of sodium is 50 milliequivalents per liter. What's the clearance of sodium? Anybody got a number? Right? what does that calculation come up to?
I think you need to change some of it. But they would cancel.
Oh, wait, no, because one.
This is- So,
Oh, I see.
hmm?
It's not a thing, the flow rate should be in liter instead of milliliter.
Well, so this is in mils per minute. This is in milliequivalents per liter. You don't have to calculate it. If this is in milliequivalents per liter, this cancels. So you don't have to convert, I mean, if you can convert them both, but why bother? What's the number? 0.43. 0.43. What are the units? Mils per minute. Why is this number so much lower than GFR in this patient? Because sodium is actively reabsorbed by the renal tubules. So what was filtered was partially, mostly reabsorbed. What is the filtered load of sodium? Okay, now we have, the filtered load is GFR times the plasma concentration. Concentration of sodium in plasma. So what was GFR? It was 114 mils per minute times the concentration of sodium, which is, now I'm going to do this in my head. Concentration of sodium in plasma is 0.14 milliequivalents per mil. See what I just did? So the filtered load, what's that filtered load? Do the calculation, I think it comes out to 16. What are the units? Milliequivalents. It's not milligrams here now because we're dealing with milliequivalents per minute. The filtered load is 16 milliequivalents per minute. Let's do the excreted load and then I think we'll be done for the day. Well, no. Remember, there's lab this afternoon. We haven't had lab in a while. There's lab this afternoon and there's a biology program that you're cordially invited. So let's do the excreted load. So the excreted load is the urine flow rate times the concentration of sodium in urine, which is equal to, this one has a 1.2 mils per minute times 0.05 milliequivalents per mil. What does that come out to? 0.06. 0.06, what are the units? Milliequivalents per minute. Why is the filtered load so much greater than the excreted load? Absorption. Okay, so and then there's a final problem with urea. You can do that at home, and so do that one at home, just to increase your knowledge about this. And then on Tuesday, we will pick up and talk about how GFR, glomerular filtration, is controlled by the sympathetic nervous system and by the macular density. We'll do that on Tuesday. That's where we're going. You don't need this for the quiz. That's why I put it at the end. You do need to understand clearance, but you don't need a calculator. You don't need a calculator. The quiz will not include a calculator. You might want to, it will ask you questions about clearance, but it won't ask you to calculate it. That's a problem set for a